Hey guys, welcome everyone. I'm Dr. Patil and welcome to this Read Harrison's with Dr. Patil series. Here we're going to spend only 30 minutes and we will understand anemia. Well, more than the laboratory medicine, today's session is going to focus more on the clinical medicine because anemia is dealt in more than adequate details in pathology, the under hematology section, and obviously pathologists are the better teachers to teach you about anemia. What I'm bringing to the table today is the clinical aspects of anemia. So what we will do is we will understand some basic clinical terms and then we will develop a basic approach whenever we diagnose someone as having anemia, how we reach the final diagnosis about the cause for anemia, right? That's what we will be covering today. So let us start with first by defining anemia, right? What is anemia? In simple words, you can say anemia refers to decreased hemoglobin or the hematocrit or RBC cell mass in the blood. That is the basic definition, right? So we say anemia as decreased hemoglobin or RBC cell mass. But to say that we have anemia, I have to also tell you what is the cutoff, right? Because like the range for hemoglobin for normalcy varies from gender, age and various factors. So we need to have a cutoff to say that okay, when hemoglobin is below this, we will call it as anemia. Now when you open standard textbooks, every book gives their own numbers for defining anemia, and for the simplicity and for the standardization, let us practice the WHO definition of anemia. So WHO definition of anemia goes like this: when hemoglobin is less than, obviously as I've already told you, we will have different numbers for males and females, and when it comes to females, we all know that during pregnancy hemoglobin level decreases for various factors. One of the important factor is expansion of the plasma volume, right? Because there is increase in the plasma volume during pregnancy, there is dilution of the blood, and when we dilute, the concentration of substances in the blood obviously comes down. So hemoglobin during pregnancy is slightly lower than the non-pregnant female. So we need to have three cutoffs, one for males and one for non-pregnant females and one for pregnant females, right? So can anybody comment down and tell me what is the cutoff? Good evening, Nuseba. What is the cutoff for a male to say that he is anemic? Well, remember, a male is said to be anemic when his hemoglobin level is less than 13 grams per deciliter. MD Cat Guide absolutely right. So a male is said to be anemic when his hemoglobin level is less than 13 grams per deciliter. Right? Then a non-pregnant female will be called as anemic when her hemoglobin level is less than 12 grams per deciliter, and a pregnant woman would be called as anemic when her hemoglobin level is less than 11 grams per deciliter. So this is kind of easy to remember, right? Just three numbers: 13, 12 and 11. Males less than 13, non-pregnant females less than 12, and pregnant women less than 11 grams per deciliter. We will call them as having anemia, right? Now as a clinician, how will I get to know whether a particular person is having anemia? Obviously based on the symptoms and signs. So now when hemoglobin level or red cell mass decreases, what symptoms do you expect? What is the most common symptom that these patients would come to the hospital? What could be the most common symptom that a patient with anemia come to the hospital with? Right, the most common symptom is going to be fatigue, because your tissues are now not going to get the sufficient oxygen delivery because your hemoglobin level is less. Hemoglobin is the oxygen transporter. So if tissues are deprived of oxygen, obviously they will not be able to do a good job. So thus you start experiencing fatigue. So the most common symptom of anemia is going to be fatigue. Okay. Now with fatigue, or you can also call it as weakness. Now with long-standing severe anemia, patients can even experience complications, and those complications include even heart failure. So patients with anemia, if severe anemia, they can develop heart failure. Yes, apart from fatigue, they can experience shortness of breath or breathlessness. And in severe cases, they can develop heart failure. That is why whenever you describe in case presentation that, sir, I am dealing with a patient with anemia, you should mention, this is what examiners expect, you should mention that whether the patient is in failure or not. So you should mention, sir, this is a case of anemia, probably nutritional or probably because of B12 iron deficiency or whatever is the cause. probably because of this cause, and patient currently is in failure or patient currently is not in failure. That completes our description of anemia for the case presentations. Now what signs to expect? Yes, the most important sign that we would expect is pallor, right? Now that begs the question, what do I mean by pallor? Pallor refers to paleness of MBBS. I'll tell you how heart failure develops because of anemia. There are two reasons. One, if the hemoglobin level in the blood is less, so obviously that means the amount of oxygen given to the tissues by the blood will come down, because hemoglobin is the oxygen transporter. So if tissues are not getting sufficient blood supply, right, so they will send various neurohormonal mediators to tell the heart that okay, we are not getting sufficient oxygen. So what heart should do now? Heart should do more work so that heart can deliver more blood. If I am not able to deliver sufficient oxygen because of the decreased oxygen carrying capacity of the blood, by giving more blood to the tissues, I can make sure that your tissues get sufficient oxygen, right? But to increase the blood supply to the tissues, heart needs to do more work, right? So there is increased workload on the heart, and obviously heart is also getting its oxygen from the blood itself. So if the hemoglobin is low, on one hand its workload is increased, on the other hand the oxygen delivered to the heart itself is decreased. So what is the end result? There is a clear mismatch between the amount of oxygen that heart needs and the amount of oxygen that it is getting, and we end up developing heart failure. Okay, so pallor refers to paleness of skin and or mucous membranes. Skin and or mucous membranes. Okay, now what are the ideal sites to look for the pallor? Because the moment you finish history, right, regardless of what case you're presenting, in your bedside discussion, the first thing you would utter is, when you go to the examination, is about the general physical examination. There you probably start with the consciousness, orientation, and then you come to the pickle, right? You would say, sir, patient is having pallor or patient is not having pallor, and most of the examiners would say, look for the pallor in front of me, and they expect you to demonstrate how to look for the pallor, right? So the question is, what are the sites to look for pallor? Yes, the most common and the most convenient site to look for pallor is the lower palpebral conjunctiva. Lower palpebral conjunctiva, that is the most commonly followed site. Okay, now I will give you an image. Look at this image and tell me whether this patient has pallor or not. Most of you commented, sir, lower palpebral conjunctiva. Absolutely right. Now look at this image and tell me whether this patient has pallor or not. I am going to see, once the patient develops anemia, the initial symptoms will be fatigue, lethargy or weakness, and maybe some degree of shortness of breath. But as the anemia progresses, he will develop heart failure, and once he or she develops heart failure, they will start developing the pedal edema, orthopnea, paroxysmal nocturnal dyspnea, and in more advanced conditions they can even develop the pulmonary edema. In that case they will be even severely breathless. So all these symptoms we can expect. Yes, so Nikita says that this patient has got pallor. Absolutely right. Okay, I will show you one more image. Do you think this patient has got the pallor? Do you think this patient has got the pallor? I know most of you will say, no sir, the patient does not have pallor. So what is the difference between these two images? Now some of you may say, sir, redness, right? No, this is one common mistake that we do. See, redness becomes very subjective term. So first let me tell you why we use lower palpebral conjunctiva as the site for looking for pallor. See, when I have to look for the drop in hemoglobin or the anemia, I have to see the blood, right? And because conjunctiva is relatively transparent or translucent, it is more easier for us to visualize the blood vessels in them, right? Now there are different sides of the conjunctiva. The conjunctiva on the eyeball is what we call as the bulbar conjunctiva, and the conjunctiva behind the eyelids is what we call as the palpebral conjunctiva. The one behind the lower eyelid is what we call as the lower palpebral conjunctiva. Okay. Now conjunctiva being translucent becomes an ideal site for us to look for the blood, right? Okay. Now when you look at the normal lower palpebral conjunctiva, this lower palpebral conjunctiva has an anterior portion means this portion, and has a posterior portion. Normally posterior portion is slightly more paler than the anterior portion. So the anterior portion, this rim you see, looks much redder than the posterior portion that I am highlighting here. Okay, so you will say that a particular person has pallor when the anterior portion of the lower palpebral conjunctiva becomes as pale as the posterior. So you are not able to differentiate the two colors. Then we will say that patient has got the pallor. So when you look at this image, you can clearly notice that the anterior portion and the posterior portion are equally pale, right? The anterior portion is not redder than the posterior portion. That means the patient clearly has pallor. On the other hand, in this image, the anterior portion is much red in comparison to this posterior portion. So that means there is no pallor. Clear? Okay. So now we know how to look for where to look for the pallor and how to identify the presence of pallor in the lower palpebral conjunctiva. Okay. Now what other sites we can use for looking for the pallor? We can also look at the tip of the tongue, the soft palate, nail beds, skin, palmar and plantar creases. Palmar and plantar creases are particularly important because when the palmar or plantar creases become pale, it also tells you that hemoglobin is below certain number. Can anybody comment and tell me what number I am referring to? See, when you look at my palms, right, you can notice that my palmar creases are darker, right? They are slightly more pigmented than my rest of the palmar surface. They are darker, right? But if the creases are also as pale as the rest of the palm, then it indicates that hemoglobin is below certain level. Okay, can anybody tell me what hemoglobin level we can think of? So please remember, whenever there is pallor of the palmar or plantar creases, it indicates that hemoglobin is less than 7 grams per deciliter. And this is a very, very important point, because to sustain the functions of vital internal organs, means your liver, kidney, heart and other vital organs, we need to maintain hemoglobin level 7 or more than 7. Whenever hemoglobin level is less than 7, the internal organs are not getting sufficient oxygen and they slowly start losing the function, just like how we are developing heart failure. MBBS heart failure can happen in both the settings. The acute blood loss can also lead to heart failure, which is typically acute decompensated heart failure or acute heart failure. And the chronic blood loss is more commonly, or chronic anemia is more commonly associated with heart failure than acute, because when we lose blood acutely, there are compensatory mechanisms, like you can develop the vasoconstriction, increase in the catecholamines. They will try to maintain your blood pressure and reduce the risk of, or reduce the chance of developing heart failure. And mostly the nature of acute blood loss makes you reach the hospital quick. And then generally, as doctors, the moment I see hemoglobin less than 7, I will initiate transfusion. So we maintain the hemoglobin levels by transfusion, and the chances of an acute blood loss patient going into heart failure is reduced by the presence of clinical features and early presentation to the hospital. But those patients who are chronically anemic, right, they are the ones who often come to hospital in a stage of heart failure. Okay. Yes, it is a high output heart failure, because the failure is happening because the cardiac output is increased. The cardiac output is increased because the tissues are deprived of the oxygen that they need. So the neurohormonal mechanisms are increasing the heart rate as well as the cardiac contractility. Okay, so palmar and plantar creases are very, very important because it points that hemoglobin is less than 7 grams per deciliter, and hemoglobin 7 grams per deciliter is a critical number. Less than this, we might start losing the internal organ function. And that is why you open any hematology textbook or any medical condition and there comes a question: when should we consider blood transfusion? Right? The threshold for transfusing blood is when hemoglobin is less than 7 grams per deciliter. Okay, now I have one question. What pallor indicates? Can I say pallor is equal to anemia, or am I wrong if I say so? Can I say pallor is equal to anemia, or am I wrong if I say so? So guys, please remember, pallor is not equal to anemia. Is not equal to anemia. Pallor basically means the amount of oxygenated hemoglobin reaching the site where you're looking for pallor is reduced. So that can be either there is a genuine reduction in the hemoglobin, that is anemia, or there is reduction in the perfusion of the tissues. For example, I'll just give you an example, right? Take your hands, now go to your fridge, open the fridge, right? Take some ice cold water or something and dip your hand in it for a few seconds and take it out. What do you notice? Your hands become pale, right? Why have they become pale? Because immersion to the cold water resulted in vasoconstriction. So when blood vessels coming to the palms constricted, less oxygenated blood came to the palms, right? So the amount of hemoglobin in the palm at that point of time is reduced. So we will look, it will appear as pallor. But does that mean our hemoglobin in the blood is reduced? No, the amount of hemoglobin reaching the palm is reduced, right? So that's why I said pallor is not always equal to anemia. So pallor can indicate, number one, decreased in hemoglobin, right? Or it can also indicate decreased tissue perfusion, or it can also indicate hypoxia. It can also indicate hypoxia. Okay, when the tissue perfusion can get decreased, tissue perfusion can get decreased when there is vasoconstriction. Vasoconstriction. Can anybody tell me what all hormones can cause vasoconstriction, or what are substances that are known to cause vasoconstriction? Second, okay, if there is decreased circulatory blood volume, which is essentially nothing but a form of shock. Yes, angiotensin 2 is a very potent vasoconstrictor, right? Apart from that, adrenaline, noradrenaline, dopamine are potent vasoconstrictors, right? So when these substances are administered for someone's BP to be elevated in hypotensive conditions, we can develop vasoconstriction, we can develop pallor, right? So tissue perfusion can also be decreased on exposure to cold. Exposure to cold. Yes, collectively, yes, adrenaline, noradrenaline, dopamine, collectively we call them as catecholamines, right? On exposure to cold, even a normal individual can develop vasoconstriction and pallor, and in some individuals it can be exaggerated, means much more than normal physiological level of vasoconstriction can happen in some individuals. In that case, we call it as Raynaud's phenomenon. You might have heard about it, right? Raynaud's phenomenon is also of two types. The primary Raynaud's disease, where the physiological response of vasoconstriction is exaggerated, or it can be also secondary Raynaud's phenomenon, like you see in patients with scleroderma, where pathologically there are some abnormalities of the blood vessels, and because of that the blood flow through those vessels is reduced. So I think the point is clear. If someone is having pallor, it need not always mean anemia. Anemia is one possibility, but we can also see pallor when there is decreased tissue perfusion or hypoxia. Right, Satya, CREST syndrome, or what you also call as scleroderma, one of the manifestation or the collection of symptoms of scleroderma is CREST syndrome. Okay. Now, before we go to the laboratory medicine, hematology is all about laboratory medicine. Most of the hematological diagnoses are done by pathologists than clinicians, but as clinician, we should also make some attempt to gauge clinically what could be the cause, what is the possible level of hemoglobin, right? So, looking at the degree of pallor, we can grade the anemia as mild, moderate and severe. Mild, moderate and severe. Okay, so we'll call it as mild pallor when pallor is affecting the conjunctiva and or mucous membrane. Conjunctiva and or mucous membrane. There is no pallor of the rest of the skin. Means these are the patients where you identify that they are anemic only when you look into their conjunctiva or the mucous membranes, right? But moderate patients, moderate anemia or moderate pallor is where there is pallor of the above, that means conjunctival and mucous membrane pallor is there, plus in addition to that there is pallor of the skin. Now these are the patients who the moment they walk into the OPD and sit in front of you, you will recognize that they are anemic because their skin is looking pale. Many a times the patients are sent to the hospital by their colleagues, friends or family members because they are looking pale. Their skin has become pale, that is moderate pallor. Severe pallor refers to pallor of the above, means conjunctiva, mucous membranes and skin, and in addition to that the pallor of palmar creases. Palmar creases. So whenever you see a patient with pallor and there is palmar crease as pale as the rest of the palm, it means it is severe anemia or there is severe pallor. And I've already told you, in most cases, it indicates that hemoglobin is less than 7 grams per deciliter. So when you look at such a patient, it is going to look somewhat like this, right? Look at this palm. Look at my palms now, right? So when you look at my palms, you can see that the palmar creases are quite pigmented compared to the rest of the skin of the palm. But look at this image. The palmar creases are as pale as rest of the palms. That means this patient has got severe pallor and this patient's hemoglobin is expected to be less than 7 grams per deciliter. Do I need the lab to gauge what could be the hemoglobin level? No, right? Clinically, we can get a rough idea about what is the anticipated hemoglobin level of the patient. Okay. We generally don't look for the pallor on the bulbar conjunctiva. We will primarily look for the palpable conjunctiva. Okay. So now clinically, pallor is the most important sign. We know how to examine now and also how to grade it as mild, moderate, severe, and what are the alternate sites for examination of the pallor. We have also learned that presence of pallor need not always be equivalent to anemia. We have learned about the cutoffs for diagnosing anemia, that is 13 grams or less for male, 12 for a non-pregnant female and 11 for the pregnant female. This is about clinical. Now coming to the laboratory medicine, right? Once I have seen a patient who has pallor, right? I have clinically identified that this is a patient with anemia. How do I proceed further? The rest of the things are mostly laboratory oriented. Now you will have many approaches to reach the conclusive diagnosis. This patient is anemic because of iron deficiency, or this patient is anemic because of B12 deficiency, or this patient has got thalassemia, or whatever is the reason. But the most practical and most commonly used approach, which is also endorsed by Harrison, is what we call as the kinetic classification of anemia. We call it as kinetic classification of anemia. There are different approaches, right? You can classify the patient with anemia as having microcytic or macrocytic, depending on the peripheral smear, right? Or you can run a battery of investigations. You can check their iron level, B12 level, right? Folic acid level, everything. But more simple and easy approach is to follow the kinetic classification. So what do we do in kinetic classification is, whenever you have a patient with anemia, the first thing that I would be interested is, obviously I would have done the CBC. I know that hemoglobin is less than 13 in a male to call it as anemia, or 12 in a non-pregnant female, or 11 in a pregnant female. Then only I will be calling it as anemia. Once I have established the laboratory diagnosis of anemia, the first thing I would like to do is calculate something called as reticulocyte production index, or RPI. Reticulocyte production index, or RPI. Now how do we calculate this reticulocyte production index? So for calculation of the the bulbar conjunctiva is exposed to the external environment, right? If you are in a heated environment, the bulbar conjunctiva, the blood vessels will be dilated, your eyes would be looking red. If you are in a cold environment, the blood vessels will be constricted, your bulbar conjunctival vessels will be looking paler, right? If some dust particle goes in, the first thing that becomes red is your bulbar conjunctiva. Because bulbar conjunctiva is exposed to external environment, it is not considered reliable. But the palpable conjunctiva is protected from the external environment, not easily or quickly influenced by the changes in the surrounding. It becomes the ideal site for us. Okay, so how to calculate the reticulocyte production index? So for us to calculate the reticulocyte production index, first thing is, from the blood counts we need to know the reticulocyte percentage, okay, and then patient's hematocrit, okay, and then there is something called as maturation factor. How to come to know the maturation factor, I'll tell you. So the formula for calculation of RPI goes like this: reticulocyte percentage multiplied by patient's hematocrit divided by 45, and this whole is divided by the maturation factor. And this maturation factor depends on the patient's hematocrit itself. So if hematocrit is more than or equal to 40%, this maturation factor is 1. So let me say I have a patient with the hematocrit 41, right? So in that case, it will be like whatever is his reticulocyte percentage into 41 divided by 45 divided by 1. That gives me the reticulocyte production index. So if the hematocrit is 39.9%, it will be 1.5. 20 to 29.9%, it will be 2, or less than 20%, it will be 2.5. right? So this is a formula that for the sake of exam we need to by heart. In clinical practice, the laboratory reports come with a printed reticulocyte production index value, or there are easily available mobile calculators or apps from which we can get to. We can just feed the information and we will get the result. So once I get to know the reticulocyte production index, if this reticulocyte production index is more than 2.5, what does that indicate? If it is more than 2.5, it indicates that the RBC production in the marrow is not disturbed. There is increased amount of RBC production happening in the marrow. See, we know that reticulocytes are the premature RBCs. So if reticulocytes are high, that means the RBC production is going on well. If the reticulocyte production index is low, that means RBC production is impaired. So if I get RPI more than 2.5, that means there is no issue with the number of RBCs produced. So such cases we call it as hyperproliferative anemias. Hyperproliferative anemias. So can anybody give me examples for hyperproliferative anemias? Where you have anemia, but it is not because of decreased production by the marrow. Most likely it is happening because your marrow is able to produce RBCs, but they are getting destroyed. So in that case, what do we call that anemia as? Where your bone marrow is producing RBCs, but unfortunately they are getting destroyed. It's like बाप कमाता है, बेटा उड़ाता जा रहा है. इसलिए गरीबी क्यों है? क्योंकि बाप कमा रहा है, लेकिन फिर भी बेटा उड़ा रहा है. Right? It indicates that you have either blood loss. You can have this kind of picture when you have acute blood loss, or as Mountain Life mentioned or Satya mentioned, you have hemolysis, where the RBCs are being lysed or destroyed. So either you are losing blood suddenly or acutely, or you have hemolytic anemias, right? Acute blood loss can happen because of various reasons. The most common cause for acute blood loss in today's practice is the road traffic accidents or trauma. The second most common reason for acute blood loss is gastrointestinal bleeds, right? When your ulcer bleeds or your hemorrhoids bleed, those are the common causes for acute blood loss. Okay. Now, can anybody tell me some causes for hemolytic anemia where RBCs are being broken down in the body or lysed? Hemolytic anemia can be further classified into two situations. One is where the destruction of the RBCs is happening because there is a problem. The destruction is happening inside the blood vessel. So in that case, we call it as intravascular hemolysis. Intravascular hemolysis. And another one is referred to as extravascular hemolysis. So basically, if the RBCs are broken down inside the blood vessel, we will call it as intravascular hemolysis. And if the RBCs are broken down in the spleen or the liver, we will call it as extravascular hemolysis. So in what conditions I can have intravascular hemolysis? Whenever, examples I can quote is if you have G6PD deficiency. G6PD deficiency, and you have a set of autoimmune disorders called as autoimmune hemolytic anemia. Autoimmune hemolytic anemia, right? The extravascular hemolysis is typically caused when you have defective RBC membrane, like your RBC is not in proper shape, and when it passes through the splenic vessels, right, it gets damaged there and it gets destroyed. So examples for extravascular hemolysis is RBC membrane defects. Can anybody give me examples for RBC membrane defects? RBC membrane defects. Yes, your hereditary spherocytosis, hereditary elliptocytosis, those are classical examples for the RBC membrane defects. Okay. Now what if the reticulocyte production index is less than 2.5? That means बेटा नहीं उड़ रहा है, बाप ही कम कमा रहा है, right? तो घर में गरीबी क्यों है? बाप कम कमा रहा है. Means your bone marrow is not able to produce sufficient RBCs. So in what condition it can happen? It can happen under two circumstances. Either there are defects in the marrow and that is why the marrow itself is not able to produce, or marrow is capable of producing, but for the RBCs that marrow is producing, it has to go through some stages of maturation, and nutrients required for that maturation are deficient, so we are not able to produce proper mature RBCs. So these are the two circumstances where we can have reticulocyte production index less than 2.5. So the first one is, we call it as hypoproliferative anemias. Hypoproliferative anemias, where the RBC precursors in the marrow are not able to produce. And the second one is when you have maturation defect. Maturation defect. The examples for the hyperproliferative anemias is when you have aplastic anemia. Can anybody tell me what aplastic anemia means? Aplastic anemia. Aplastic anemia refers to reduction in the numbers of marrow cells which are concerned with the production of RBCs, as well as in aplastic anemia the other two cell lines, the WBC precursors as well as the platelet precursors, that is megakaryocytes, all of them are reduced in number. It can be either inherited or acquired. We call it as aplastic anemia, right? You know the term hyperplasia, aplasia. Aplasia refers to reduction in the number of cells, and when we say aplastic anemia, reduction of the number of cells required for the formation of RBCs in the bone marrow. And then we have another condition called as pure red cell aplasia. The difference between aplastic anemia and pure red cell aplasia is that in pure red cell aplasia, only the RBC precursor cells are reduced in number in the marrow. In aplastic anemia, all the three cell lines, means platelets, WBCs as well as RBC precursors, are reduced in number. So these patients present usually with pancytopenia, not only anemia, they will also have decreased WBC count, and they will also have thrombocytopenia or decreased platelet count. On the other hand, patients with pure red cell aplasia, because only RBC precursor reduced, their hemoglobin hematocrit will only be decreased, and there will be no change in the platelet count or WBC count. And another example we can quote is what we call as anemia of chronic disease. I think someone had mentioned an example of CKD, which is true. CKD is a classical example for anemia of chronic disease. Anemia of chronic disease. So whenever we have long-standing diseases like, let me say, HIV or cancers, there is increase in certain inflammatory cytokines. We have been talking about a lot of cytokines in the recent sessions, like interleukin 1, interleukin 6. They suppress the bone marrow, and because they are suppressing, the bone marrow is not able to produce RBCs and hemoglobin, and that is why we have anemia. Okay. Now when it comes to maturation defects, they are generally because of nutritional deficiencies. Nutritional deficiencies, like for example iron, folic acid, B12 or zinc, right? These are the essential nutrients required for the formation of hemoglobin and proper synthesis and maturation of RBCs. So if you have B12 deficiency, iron deficiency, folic acid deficiency or zinc deficiency, you can develop anemia where your reticulocyte production index will be less than 2.5. Okay, so again, to give you a quick summary of what we have learned today, first thing, we understood that anemia refers to decrease in hemoglobin or RBC cell mass. We follow the WHO definition or the cutoffs. So when a male is having less than 13 grams per deciliter hemoglobin, we will call him as anemic. For a non-pregnant female, the cutoff is 12, and for a pregnant woman, it is 11, right? The most common symptom that a patient with anemia presents is weakness or fatigue, and to some extent mild degree of shortness of breath. But a long-standing or severe anemia can present with heart failure. In that case, patients can have all the cardinal manifestations of the heart failure, including raised JVP, pedal edema, orthopnea, PND, ascites, and tender hepatomegaly. The most common examination findings in these patients is going to be pallor. Okay, and then we learned what pallor refers to. Pallor refers to paleness of skin or mucous membranes, and whenever you see that, right, it means patient may be having anemia. Pallor is not equal to anemia. The most common site looking for the pallor is going to be lower palpebral conjunctiva. Other than that, we can also look at the tip of the tongue, soft palate, nail beds. Generally, when you look at the nail beds, because of the presence of capillaries, it looks pale. If it has become pale, you know that there is pallor. We can also look at the skin and palmar or plantar creases. And I've also told you that when the palmar or plantar creases are pale, that means hemoglobin is less than 7 grams per deciliter. Most important point that we have learned today is, how do you confidently say that this patient's lower palpebral conjunctiva shows pallor? By mainly comparing the anterior and posterior rim of the lower palpebral conjunctiva. Normally anterior rim is more redder than the posterior rim, but if both are equal in color, that means there is pallor, right? Anterior rim here is expected to be more red. If not, that means there is pallor present. Okay, I think I've already told you pallor is not always equal to anemia. Pallor can happen because of other conditions. Now we can grade the pallor as mild, moderate or severe. Mild refers to when pallor is only restricted to conjunctiva and mucous membrane and not to the skin or rest of the body. When pallor also involves the skin, we will call it as moderate, and when the palmar creases become as pale as the rest of the skin, we will call it as severe, right? And once we have recognized pallor and we think that this is anemia, the next best step is to calculate the reticulocyte production index. For us to calculate the reticulocyte production index, I need the reticulocyte percentage and hematocrit. That's it I need. So once I get that, we approach this formula. Reticulocyte production index is equal to reticulocyte percentage into hematocrit of the patient divided by the normal standard hematocrit, which is 45, and whole of this is divided by the maturation factor. The maturation factor depends on the hematocrit, right? So I have given you a table where the hematocrit value and appropriate maturation factor is mentioned. This you will study in pathology as well, and in pathology you will get MCQs based on these calculations. Do practice that. In bedside discussion we will not ask you, but we will at least ask you how do you approach a patient with anemia looking at their reticulocyte production index. So once the reticulocyte production index is calculated, if it is more than 2.5, I know it is a case of hyperproliferative anemia. Problem bone marrow में नहीं है. Bone marrow ठीक से काम कर रहा है, लेकिन वो blood जो bone marrow बना रहा है कहीं से loss हो रहा है या it is getting destroyed. So that indicates that patient has either got hemolytic anemia or acute blood loss. But if the reticulocyte production index is less than 2.5, इसका मतलब है bone marrow से ठीक से production नहीं हो रहा है. क्यों नहीं हो रहा है? या तो बोन मैरो में जो सेल प्रोड्यूस करने के लिए प्रिकर्सर सेल्स चाहिए, जो रेटिकुलोसाइट्स या उसके प्रिकर्सर्स चाहिए, वो ठीक से नहीं बन रहे हैं, लाइक बिकॉज ऑफ एप्लास्टिक एनीमिया, प्योर रेड सेल एप्लेसिया और अ लॉन्ग स्टैंडिंग डिसीज, और द फैक्टर्स रिक्वायर्ड फॉर मेचुरेशन ऑफ रेटिकुलोसाइट्स टू आरबीसीज, मेचुरेशन ऑफ हीमोग्लोबिन और सिंथेसिस ऑफ हीमोग्लोबिन लाइक आयरन, फोलिक एसिड, B12, जिंक, वो सफिशिएंट क्वांटिटी में पेशेंट के पास अवेलेबल नहीं है, एंड दैट इज व्हाई ही हैज डेवलप्ड द अनीमिया. Okay, so this is the kind of approach to anemia. In the subsequent sessions, we will, like when we go to the theory based video modules, we will discuss more about how to differentiate between intravascular and extravascular hemolytic anemias, and once we have differentiated intra and extra, how to further distinguish whether a particular patient is having autoimmune hemolytic anemia. If it is autoimmune hemolytic anemia, there are again subtypes, warm, cold, how to differentiate, all that we will take in the subsequent session. So for now, we have addressed pallor and a basic approach to anemia. I will share some MCQs on the notes based on today's learning, and in the subsequent classes, we will continue our discussion on the anemia. Okay, yes, if there's a patient who is on diuretics and he has developed heart failure, the signs and symptoms of heart failure may be partially blunted by the presence of diuretics. But even when they are taking diuretics, the edema may be difficult for us to recognize. Patient may not have significant orthopnea or PND. JVP may not be grossly elevated, but still the degree of shortness of breath and the weakness that these patients experience will be more than the degree of shortness of breath or the fatigue that a patient with a similar amount of hemoglobin without heart failure would be expecting. So as an experienced clinician, you can sense like, okay, if I'm dealing with a patient with, let me say, hemoglobin 10, right, I know that, okay, a patient with hemoglobin 10 should be able to walk into my OPD. If he's so fatigued that he can't walk, or if he's so breathless that he can't get into my OPD, उसको wheelchair से लेके आने की ज़रूरत पड़ रही है, that is where I would definitely suspect that patient may be having anemia with heart failure. And as such, today, whenever we have a long-standing anemia, as a routine practice, we do a echocardiography. Because when you do echocardiography, we can calculate ejection fraction and also the other cardiac parameters, which can also give you a clue about the presence or absence of heart failure. In your bedside discussion, all you need to say is, sir, this is a patient who has severe pallor, and with that he has signs and symptoms of heart failure. That is why I consider that this is a case of anemia in failure. And if the signs and symptoms are absent, you can say, sir, this is a patient of anemia, not in cardiac failure. In that case, if examiner says that patient is taking diuretics, then what do you think about it? You can say, sir, probably the use of diuretics or other medications might have masked the symptoms of heart failure. So in such cases, I cannot comment about the presence or absence of heart failures merely on the clinical grounds. I have to rely on the laboratory. Okay, so that's it for today, guys. I'll be signing off. So the anemia of chronic disease refers to whenever we have long-standing diseases like patients with CKD, chronic kidney disease, or even for that matter, patients with heart failure because of other reasons, or patients with long-standing hepatitis, HIV, cancers, they often develop anemia, right? In them, anemia is multifactorial, but one of the most important reason why a patient with long-standing diseases develop anemia is upregulation of inflammatory cytokines. So when you have long-standing diseases, interleukin 1, interleukin 6, they will be elevated, and these elevated interleukin 1, interleukin 6 can suppress the bone marrow, and because they're suppressing, bone marrow is not able to produce sufficient RBCs and hemoglobin, and they end up developing anemia. So in such cases, if I give them iron supplementation or iron injection, they may not respond well, right? I have to reduce the inflammatory cytokine levels by treating the underlying disease. Or maybe in some cases like anemia of CKD, I have to give erythropoietin to stimulate the bone marrow to produce more RBCs. Giving nutrients or iron may not work for them. Garam masala, see, blood transfusion is an art and a science. See, many cases blood transfusion is unnecessarily done, and sometimes when it is absolutely necessary also, it is delayed. So we should have some objective understanding of when we should transfuse the blood. Okay, so if a patient is having chronic anemia, means anemia is not developed in 2 days, like okay, tomorrow, like yesterday hemoglobin was 14, today is 10, it is an acute anemia, mostly happens because of acute blood loss, right? On the other hand, hemoglobin was 14 3 months back, slowly गिरते गिरते आज 10 तक पहुंचा है, 9 तक पहुंचा है, that is our chronic anemia. So long-standing anemias, body will go through certain compensatory changes. It will be partially accustomed to the decreased hemoglobin levels, right? So in chronic anemia patients, as long as hemoglobin is more than 7 grams per deciliter, there is no need for blood transfusion until and unless you are anticipating some blood loss कि हाँ सर्जरी करना है तो फिर सर्जरी के टाइम पे blood loss होगा, so before that we need to transfuse and keep the hemoglobin in the safer range. But otherwise, if no major invasive procedure expected, a patient with chronic anemia, as long as hemoglobin is more than 7, treat the underlying cause. अगर nutrition deficiency है, iron deficiency है, B12 deficiency, treat it, and over time the hemoglobin will get corrected. But if I have a patient with chronic anemia, hemoglobin is less than 7, transfuse na karna can be fatal to the patient, because 7 is required to sustain the vital internal organs, right? But what happens in many circumstances, you have a long-standing chronic anemia, patient hemoglobin is 10, 11, and like old timers or some quacks order transfusion because they think that okay, if I just elevate the hemoglobin to 14 or 15, patient will feel good. But those unnecessary transfusions create a lot of burdens, unnecessary transfusion reactions, transfusion related infections, and they do contribute to mortality. That is why objectively knowing when to transfuse and when not to is important. Okay, so that's it for today, guys. I'll see you in the next session. I think the topic for next session, as some of you have requested, I'm trying to bring in the more cardinal symptoms like the chest pain. So I will see if I can schedule it for the chest pain, because it's a very, very important topic for undergraduate students as well as interns. Okay, so see you in the next classes, guys. Till then, have a good time and good night. See you soon, guys. Bye-bye. Bye everyone, and thank you.